Welcome to our sonography lecture on spleen pathology, diffuse erythropoietic diseases for the sonographer, part 3 of 7. This lecture will cover sickle cell anemia, congenital spherocytosis, hemolytic anemia, autoimmune hemolytic anemia, polycythemia, vera, and thalassemia. We will begin with sickle cell anemia. So sickle cell anemia is an inherited disease, and it causes the red blood cells to be misshapen. And the way that they're misshapen is that they show up as sickles or like crescent moons. And we learned in the spleen physiology that the spleen is really good at taking out the blood cells that aren't functioning anymore or that have aged beyond being function. And what usually happens is that those red blood cells get a little funky, they get caught up in the spleen filtering system, and then they're destroyed. Well, when you have red blood cells that aren't the right shape, that aren't that biconcave disc shape like all the other ones are, then the spleen is like, nope, get rid of them, get them out of here. And it gets stuck on taking out these misshapen cells. So any of these diseases that we talk about, like sickle cell anemia, that cause misshapen red blood cells to be formed, is really going to involve the spleen. So coming back around to sickle cell anemia, those sickle cell red blood cells get stuck in the spleen, and it actually causes problems not only in the spleen but in other parts of the body. Because remember, the capillaries are very, very tiny and are made to transport those small disc-shaped red blood cells. So again, if we have odd or misshapen red blood cells, that can cause problems in other places. What usually ends up happening is that these sickle cell red blood cells end up getting stuck and cause inadequate amounts of blood flow and oxygen to get to the organs that they need to get to. Therefore, that leads to damage of the organs. As I mentioned before, sickle cell anemia is an inherited disease. It happens to be the most common inherited disease among African Americans in the United States. Sickle cell anemia is going to first present in infants and children. Again, these children have inherited this disease from the moment they were born. They already have these misshapen red blood cells. It just kind of depends on how the body handles them. So the first thing that they're going to present with, most likely, is some sort of sickle cell crisis. And in the sickle cell crisis, the patient is going to present with fever and severe pain. What ends up happening is that the red blood cells are getting stuck in places, causing not enough oxygen to get to organs, and that's very painful when parts of the body start to kind of die off, start to become deoxygenated. They're also going to present with decreases in hematocrit. Oftentimes, the blockage of blood flow into an area can cause hemorrhage behind it, and so we will see a decrease in hematocrit, meaning that there's an active bleed somewhere within the body. Now, the other thing that we see with infants and children, when this acute crisis happens, their spleen actually becomes very enlarged, and that is because of red pulp congestion. Remember, the spleen is trying to get rid of all those red blood cells, so it's pulling out all those crescent-shaped ones. It's getting kind of overloaded in the red pulp area. At the same time, it also has red blood cells that are getting stuck and causing the spleen to start to infarct or to start to die off. And so we see this large spleen. They're in a sickle cell crisis. They go to the hospital, they get some treatment, and they are typically able to help the child through this crisis. And then everything kind of calms down, it starts to heal itself, but we've also already have a chunk of the spleen that has died off. And then it is not uncommon for them to have another crisis later, and the same thing happens. A big chunk of the spleen is going to die off, and it keeps happening. And what ends up happening is a lot of these kiddos end up having no spleen by the age of 5 because of these cycles of these crises causing the spleen to enlarge and then chunks of it to infarct and die off. And so when the body gets rid of its own spleen, it's called an autosplenectomy. So if you have a child or an adult who has a history of sickle cell anemia, it is not uncommon that you're not going to find a spleen because their body got rid of their own spleen by the time they were age 5. So on ultrasound, if we are scanning a child going through an acute sequestration syndrome or going through a crisis, we're going to see that splenomegaly. We're going to see a very large spleen due to the fact that there's just so much blood pooling in the spleen. If we see them on a regular day and we're just kind of following up, or they have a history of sickle cell anemia, no acute process going on, quite often we're not going to find a spleen because of the autosplenectomy. Sometimes we can find kind of leftovers of the spleen, if you will. Consider it that way. Those are going to be very, very small, and it might look calcified because the body is just kind of over it, walled it off, it's done with it. Now the other thing we might see are some splenic abscesses in the body as the spleen becomes damaged from those red blood cells being in there. It can cause an infection, and that can progress into a splenic abscess. So here is a couple examples of CTs compared to the ultrasound findings. In this top example here, we have a anterior posterior view of the abdomen, and this is the spleen right here. This tiny itty bitty little thing is the spleen. On ultrasound then, we're just seeing a small sliver of that spleen. So this child has not quite gone through complete autosplenectomy, but this is quite a bit smaller than what we would expect. Down in this example here, we have a transverse slice. It looks like maybe an MRI on this one. This is a spleen right here. So typically that spleen does take up a good portion of that left upper quadrant. It has now been degraded down to just this little piece. And again, we can see just a little sliver of it in the corner here. So these spleens are very, very difficult to find. I would suggest trying to look back at any previous imaging that you can find and just do your best. It is not uncommon for them to be gone completely. Next up, we have congenital spherocytosis. And congenital spherocytosis is again another inherited disease. And this time it causes the red blood cells to become sphere-shaped or big balls. So normally we have flat biconcave discs. Congenital spherocytosis causes some of the blood cells to become ball-shaped. And as we've been talking about, the spleen is responsible for getting rid of those kind of oddball red blood cells. And so when you have a bunch of them that are ball-shaped, the spleen zeroes in on them and gets rid of them. Well, if you get rid of too many of your red blood cells, that is considered anemia. There aren't enough red blood cells circulating through the body. When there's not enough red blood cells, we don't have enough iron, we don't have enough oxygen circulating through the body. Now, because these are congenital, we typically see these patients present very early in childhood, and the best treatment for congenital spherocytosis is to get rid of the spleen. Get rid of the spleen, it'll stop the abnormal destruction of the red blood cells, but it doesn't cause the red blood cells become the right shape anymore. They stay abnormal shape, but they are no longer destroying these abnormal blood cells. The clinical signs and symptoms that go along with congenital spherocytosis are going to match up mostly because of the anemia. So we have paleness, jaundice, and gallbladder problems that go along with it. On ultrasound, we will see splenomegaly. So here's a patient with congenital spherocytosis. The spleen is very large. Again, we are missing the inferior portion of the spleen. Sonographer is guessing here where it would end. Do your best to maybe try wide scan or do a side-by-side, do a panoramic. See if you can't include both the superior and inferior pole in your pictures to get a more accurate measurement by ultrasound. But we can see this one is measuring at least 14.7 centimeters, and that is because the spleen is being overworked by having to destroy all of those ball-shaped red blood cells. Our next couple diseases talk a little bit more about the anemia side of things. So we're going to talk about hemolytic anemia in a general sense. And hemolytic anemia generally applies to the decreased life of erythrocytes. So that means shortened life of the red blood cells. So when we see a patient come in with hemolytic anemia, it typically means that the spleen is destroying more of the red blood cells than the bone marrow can make up for. So the spleen is just pitting and culling those red blood cells left and right. The bone marrow is trying to keep up with it, but it can't. And when that happens, we are low on our red blood cell count. That makes us anemic. And the main type of hemolytic anemia is autoimmune hemolytic anemia. So autoimmune hemolytic anemia comes from when the body attacks its own blood cells. There are two variants of autoimmune hemolytic anemia. The first one is primary, where the body just is out of whack and just starts attacking its own red blood cells without an underlying disease. So the spleen is just going for it. It's just taking all the red blood cells out that it wants. The other variant of autoimmune hemolytic anemia is secondary, and that is when it is seen with other diseases. Those other diseases can include lymphoma, leukemia, or infectious mononucleosis. Quite often we just refer to this as mono, the kissing disease. Treatment for autoimmune hemolytic anemia. There really isn't any treatment if it's mild. You're just going to be encouraged to eat more iron-rich foods. Should be able to overcome the anemia part of it. Moderate autoimmune hemolytic anemia may require some type of steroids to be taken. And in severe cases, we might see that the spleen is removed. So if a patient has a history of autoimmune hemolytic anemia, they may not have a spleen. So it's important to understand their history and ask any questions about previous surgeries. Now, in the very severe cases of autoimmune hemolytic anemia, if the splenectomy doesn't work, then they can also take immunosuppressive drugs to help slow down the destruction of the red blood cells. On ultrasound, then, we are going to see splenomegaly if it is the primary version of autoimmune hemolytic anemia. Remember, the primary version does not have an associated disease, so we just see that the spleen is rather large because it's being overworked. Now, if it is secondary hemolytic anemia, then the appearance of the spleen is actually going to be variable, and it's going to more match up with what is causing the secondary hemolytic anemia. Is it leukemia? Is it lymphoma? That might lead to more lesions being seen on the spleen. So here again is a very, very large spleen. We can see a little bit of the kidney here. That's the left kidney. The rest of this picture is all spleen. So again, we have a very enlarged spleen because it is being overworked, destroying the red blood cells. Our next disease is polycythemia vera. Now, polycythemia vera is actually a bone marrow disorder, and this is going to cause the bone marrow to create too many red blood cells. So we talked about the anemias cause the body to attack the red blood cells, making too few, and that leaves us with too few red blood cells. In polycythemia vera, the bone marrow is just kicking out red blood cells left and right, and that means there's too many. And when there's too many red blood cells, it makes the blood really, really thick. And when the blood gets really thick, the spleen is responsible for getting rid of some of those, for thinning it out. And so it's got a lot of work to do. And it makes it really hard for the heart to pump that blood through, especially through the capillaries, if the blood is too thick. So it can cause quite a few systemic issues. Now, the incidence of polycythemia vera is that it's actually very rare. Men are more likely to have it, and when they present, they're usually under the age of 40. Clinically, these patients are going to have symptoms that are related to that really thick blood. So we're going to see weakness and fatigue. We're going to see dizziness, tinnitus, irritability, splenomegaly. Might see some flushing of the face. We'll see redness and pain in the extremities because the blood can't get into the small capillaries of the arms or the fingers or the toes. We might also see some black and blue spots on the limbs as well. So basically, it's just like sludge trying to get pushed through these itty bitty vessels. The body's not very good at doing it. We get symptoms because of that. Now, the treatment for polycythemia vera is to reduce the thickness, and the best way to do that is to actually remove blood from the body. So the first treatment is to remove about 1 pint of blood per week until the hematocrit reduces down into a normal range. On ultrasound with a patient with polycythemia vera, we will see splenomegaly, and because that thick blood can be very hard to pump through the small vessels, we might actually start to see some infections on the spleen and possibly some thromboses, blood clots in the venous portion. And again, here is a patient with polycythemia vera, a very large spleen, due to the fact that the spleen is being overworked. Our last disease then is thalassemia. Thalassemia is another blood disorder that is inherited, and this causes the body to form inadequate amounts of hemoglobin. So hemoglobin is a protein that we see on red blood cells, and if the hemoglobin is not there, then the red blood cells are not able to carry oxygen. So again, we're losing out on oxygen to our organs with thalassemia. That usually equals bad news for the organs. The other thing with thalassemia is that the red blood cells are abnormal shaped. They take on more of a target shape. And because of this abnormal shape, the spleen is going to start to destroy them. On ultrasound, we will see splenomegaly. And again, a very large spleen showing the splenomegaly due to the overworking that thalassemia is causing. So here I have another chart for you to look at. Remember that these are diffuse erythropoietic diseases. So that means the erythropoietic part means something is wrong with the creation of the red blood cells. These all have to do with red blood cells. We can see that sickle cell anemia, spherocytosis, and thalassemia all cause the red blood cells to be the wrong shape, which increases the destruction of them. In the anemias, we have normal shaped red blood cells, but the body is destroying them abnormally fast. In polycythemia vera, we have too many red blood cells, and the body doesn't know what to do with it because the blood is too thick. Again, we're going to see splenomegaly in all of these patients, mostly because the spleen is being overworked. Some other key findings: sickle cell anemia patients will technically have an autosplenectomy, usually by the time that they're age 5. Similarly, spherocytosis, the spleen will be removed to help treat the disease by the age of 5. Remember that autoimmune hemolytic anemia can be primary or secondary. Polycythemia vera is more related to the bone marrow and the overproduction of red blood cells, and thalassemia causes the red blood cells not to be able to carry oxygen very well. That brings us to the end of part 3. Next up we have part 4, some other diffuse diseases of the spleen.